This Week in Virology, the podcast about viruses, the kind that make you sick. From Microbe TV, this is TWiV. This Week in Virology, episode 1276, recorded on December 4th, 2025. I'm Vincent Racaniello, and you're listening to the podcast all about viruses. Joining me today from New York, Daniel Griffin.
Hello, everyone.
We've got a bow tie with green and red. What is this, a holiday bow tie, Daniel?
Yeah, I think you must be getting some of that low quality video that will be fixed in the final recording. It is my anthrax.
Okay.
Gram positive, gram variable rods.
Okay.
Yeah. And I'm trying to bring out the red with the pocket square. So we'll see. But let's jump right in because, oh my gosh, Vincent,
Oh my gosh, every week it gets worse, doesn't it?
I have to admit, this was one of those weeks where it just I actually felt sick. I was like, I feel sick. I can't believe what's going on. So it seemed appropriate to quote Hunter S. Thompson. It probably dates us, Vincent, right? That you and I know Hunter S. Thompson. He actually used to live in Colorado, where I'm headed tomorrow night. He lived up the valley from where I lived. I was being a ski bum in Aspen, and they were talking about how they needed to get the riffraff off the mountain, and we realized that they were referring to us. But you could go up the valley, headed west towards Glenwood Springs, and then you took a road off, and there was a bar there where a hunter would occasionally just show up. So here we'll quote, "There is no such thing as paranoia. Your worst fears can come true at any moment."
It's true. It's happening right now.
Oh my gosh. So I'm going to start off with just a little bit of actual science before we talk about why that seemed appropriate. And this was actually something I was talking with a couple of the hospitalists today. This whole connection between dementia and the chicken pox virus, I like to call it, varicella zoster virus, the shingles virus, you could call it as well. And we've been following this story, and it only gets better. I mean, we're really learning a lot about this. And this whole connection. Does the chickenpox virus reactivation, the varicella zoster virus reactivation, maybe explain a lot of the dementia we see? And so this is another article. This was published in Cell, the effect of shingles vaccination at different stages of the dementia disease course. So this study took advantage of something that we've discussed before, and this is the fact that individuals who had their 80th birthday just after the date of the herpes zoster vaccination program, folks in Wales, you'd be eligible if you were younger, but if you were if that was your birthday cutoff, you never got it and you stayed ineligible for life. So you had this midnight sort of bifurcation of the two groups, and you could look at the two groups, those who just didn't make the cutoff versus those who just barely made the cutoff. And previously, this situation allowed us to see that the herpes zoster vaccination, they're using the attenuated vaccine, reduced the new dementia diagnosis. But here, they're looking at mild cognitive impairment diagnosis. And actually, the folks that have dementia, they're looking at deaths due to dementia. And just to give context, we've seen similar data here in the U.S. where we use the protein-based Zostavax, right? This is
Shingrix.
More Shingrix, because I guess this is Zostavax, and we moved on to Shingrix.
That's right.
Okay, perfect. So this data set consisted of 304,940 individuals born between September 1st, 1925, September 1st, 1942, who are alive and residing in Wales. As of September 1st, 2013. Of these individuals, 282,557 did not have a record of any cognitive impairment prior to September 1st, 2013. And so they're included in this study as the cohort for analyzing the effect of the shingles vaccine on getting MCI, so mild cognitive impairment. the study cohort for analyzing the effect of the shingles vaccine on deaths due to dementia, here we had 14,350 individuals who had a diagnosis of dementia prior to September 1st, 2013. So among the individuals without any record of cognitive impairment prior to the start of the vaccination program, being born the 1 week before and thus being eligible, compared to those folks that were ineligible because they're just a little bit older, they saw an abrupt increase in the probability of ever receiving the vaccine, right? So, if you're eligible, you're more likely to actually get it, but only about 45.9%. So only about half of the eligible people actually got the vaccine. So that's going to dilute to some effect, the effect if we're just looking at the age cutoff. But the corresponding abrupt increase among patients living with dementia, we're also seeing that. If you were eligible but had dementia before this vaccination program, we saw that, initially no one was getting it. Now we have eligibility, 28.7. So unfortunately, a little more than a quarter, only about a third of the folks with dementia get the vaccine, right? So no dementia, you're eligible, no cognitive impairment, about half of them get it. People with dementia, quarter or third get it. So then they're going to actually look at the diagnosis, this mild cognitive impairment over 9 years, and they actually see that those eligible for vaccination had a decreased occurrence of new diagnoses, but actually getting the vaccine was where you really saw the reduction. I mean, just being eligible, you can't really expect to get you any benefit from the vaccine if you don't actually get it. And they also saw the occurrence of deaths due to dementia over this 9-year period, again, was reduced, but really you were seeing the benefit in folks that actually got the vaccine. And they got these nice figures where it becomes much more clear. I assume you're looking at the figures there, Vincent, but it is sort of funny. Like you look at eligibility and there's this wide confidence interval, but then you actually look at folks that got the vaccine and then you see the reduction in the narrow confidence intervals.
Yeah, it's a good reduction. Yeah.
Yeah. So kind of nice, encouraging everyone to get the shingles vaccine. And it's really interesting, so the people with dementia, the fact that you can actually reduce their risk of dying, it looks like they were sort of being neglected, right? Only about a quarter, a third of them were even getting it. So.
Yeah. So if you know someone who has dementia, make sure they get this vaccine. Yeah.
Yeah. And if you know someone with mild cognitive impairment, make sure they get it. And if you know someone just over the age of 50 who doesn't want to become cognitively impaired or demented.
Well, I got Shingrix, so hopefully I'm set.
It's really interesting, right? I mean, I wonder, I was talking to some folks the other day, and maybe I have odd conversations, Vincent, but, we talk about there's sort of an age-expected decrease in memory, sort of an age-expected cognitive impairment that we see. But that's not true. Not everyone. I mean, I run into patients in their late 90s who are just sharp as tacks. Yeah. And so I'm beginning to wonder how much of, used to be, everyone sort of has a stroke in their 70s. That's kind of expected. And now we're like, no, you can actually prevent that. And, everyone starts having a little bit of memory and other issues. That's just sort of what happens with aging. Maybe not. Maybe we can prevent a lot of that.
How do you prevent strokes, Daniel?
So blood pressure control. Actually prevents strokes more than it prevents heart attacks. Also, we realize a lot of atherosclerotic disease, so you can actually, impact that with cholesterol control, medications, diet, and exercise. So.
My cholesterol is 140.
Is that your total cholesterol?
Yes.
Man, that's awesome.
It's been like that my whole life.
That's awesome. The last time I had my LDL checked, I think it was 37. So I'm also hoping to just live forever. So I just don't want to be cognitively impaired.
No. Well, we keep doing this podcast. We'll use our minds, so we'll be good.
I think that we'll have to study that. I think that's going to be the, people who podcast into their 90s, right?
Well, I think you can't just ramble on a podcast, right? You have to do what we do. We read papers, we think about them, we talk about the outcomes and so forth.
Yeah, I do think there needs to be some sort of intellectual rigor. Yes. You have to actually use your mind, not just your vocal cords.
Yes. Now, that will not apply to this following story.
Yeah, this actually, I found this really upsetting.
Incredibly upsetting.
Yeah. I mean, so you've got this group of people that, they're out there like, I don't know, basically as if they made some great revelation. Like, hey, I discovered that if you go to, McDonald's and eat ultra processed foods, it's bad for you. No one knew. I'm like, oh my gosh, what? We've been saying that forever, right? Like, oh, and by the way, now that I've got your attention and you think I'm brilliant, then they come in with stuff like this. And so Dr. Vinay Prasad, who is not an immunologist, he's not a vaccine specialist, he basically sent out a memo, and I don't know if they meant for this to be leaked or it was, leaked accidentally. But basically, he sent out a memo last Friday, about a week ago. So when this drops, it'll be like, 8 days before the Saturday morning that this drops, claiming that a new review of records linked 10 children deaths to the COVID vaccine. And then, and in the verbiage, these deaths are related to vaccination, and then puts in quotes, likely, probable, possible. I mean, which of those? I mean, is it possible? Okay, that says nothing. Is it probable? That means something. Is it likely? Because if this is actually true and there's evidence, I think a lot of, like, all of us would want to know this. So the idea that
he presented no evidence.
Yeah. Well, I guess it's this leaked memo. So just to kind of like, where there's smoke, there's fire. I guess.
Even the memo doesn't give you any evidence except to say they discovered something in the VAERS database, which, as you know, can mean nothing. It's an association. I don't even know what they looked at. I don't know what vaccines. They say COVID vaccines, but which one? We don't know the interval. We don't know if an autopsy was done. We don't know if the kids have any other infection. This is the worst science of all, to make conclusions from the VAERS database, right?
Yeah, I mean, the letter doesn't seem like it's written by someone who has any kind of academic rigor. And I'll leave in a link. I mean, you can actually read this memo.
This is a horrible example of the misuse of the VAERS database. Because what it is an open database run by the CDC and FDA. You can write in and say, I got the COVID vaccine, and the next day I turned into Hulk Hogan. You can put that in there because someone has done it.
Yeah, you could actually.
And so it's full of drivel. And they say they poured through it and found 10 kids who died from the COVID vaccines. But, 10 kids died. Who knows whether the vaccine had anything to do with it? You need to do those studies, and they haven't done it. And he is saying for the first time the FDA will admit that COVID vaccines have killed children. This is a wrong statement to make. It is completely disingenuous.
Yeah.
I'm sorry I took over your narrative.
No, I'm glad you did. You always get a little more riled up than I do.
It's because you're a doctor and you're meant to be calm. But the letter is just so smarmy and disingenuous. And then at the end he says, this has to be discussed within the FDA. But if you don't agree with me, you need to quit.
Yeah, so that actually, we'll start with that because that was really like the conclusion is terrible. He starts off with, anyway, this is how I feel. And by the way, if you're not on board with my agenda, you should quit. That's not what the FDA is supposed to be about. It's actually supposed to be trying to find the truth. There should be dialogue. You don't want, this is not like if you don't agree with my regime, you need to leave. This is not, if you don't support the party line, then go.
So Daniel, if you don't agree with me, should I fire you?
It's crazy. So
it's ridiculous.
Please submit your resignation
says,
letters to your supervisor and CC my deputy, Catherine.
And then he says, if you want to remain, let's help elevate vaccine science to 21st century evidence-based medicine. And there is no evidence whatsoever in this letter that he's written to thousands of FDA employees. And he's saying we need evidence-based medicine. There's nothing in here. It's a mining of the VAERS database, by the way, by this woman, Dr. Hogue, who is a sports medicine physician, knows nothing about immunology or vaccines. Another example of how this administration puts people who are unqualified in roles of importance. In fact, Makary hired her or put her on a task earlier this year to find people who were killed by the COVID vaccine. He said, find people in the VAERS database who were killed by the COVID vaccine. And we don't even know what the deaths are. I mean, we don't know if it's myocarditis. Myocarditis from COVID vaccines doesn't usually kill you, does it?
Well, so that's those are some of the interesting flaws. So he does talk about myocarditis, and we've talked about the data on myocarditis. And when we initially saw it, it was then recommended that we space them out, and we really have not seen myocarditis. And then we compared the myocarditis that you get from vaccination to the much higher incidence and much more severe myocarditis that you get if you get COVID without the protection of a vaccine. So when it comes to myocarditis, if you want to protect the heart, you're safe for getting the vaccine, right? So they just gloss right over that. And if anything, they sort of are squirmy about it. They also, it's a very accusatory letter. It really is basically like, you knew this, you hid this data. They name names of their, I guess, political enemies that they're going to go after. This is not written like, we really want to protect children and find out the truth.
He said, now we're going to change vaccine procedures. We're not going to grant marketing authorization to vaccines in pregnant women, and we're not going to use antibody titers. We're going to look at multiple vaccines. We're going to, he says it's a concern of everyone that multiple vaccines are bad. So we're going to move away from this. Vaccines will be treated like all other medication classes.
Yeah.
And it's just reflecting a person who knows nothing about vaccines and their safety testing. Nothing.
Yeah. Yeah. No, I mean, this is, and I preaching to the choir maybe, but maybe our choir needs to share the message.
Well, this man in any other administration would never have this job because he's unqualified.
Yeah, and this is an orchestrated attack on the health of Americans, orchestrated attack on vaccines, and all done for personal, political, and monetary gain from what we're seeing. I mean, this is a anti-science lawyer leading the charge, and then they basically put people willing to do their bidding under them. And yeah, I mean, we've seen 7 children die of pertussis just in the last year. We've seen children die of measles. I had a woman here in the local area who died of pertussis in her 50s. I have a woman now in the hospital, and she's got, Haemophilus influenza, another vaccine-preventable disease, because she runs a daycare and kids are not getting vaccinated anymore. So diseases that I hadn't seen since my training that had been, cleared out by vaccinations are now coming back, and people are dying. People are getting sick. And, but by the way, he thinks we should stop eating at McDonald's until they start deep frying the fries in lard again or something. I just don't, I don't get it.
I don't understand what he says. I'm open to vigorous discussions and debate on this. And then he says, if you don't agree with me, you're fired. This guy he's got a problem. Okay. He really has a problem.
Yeah, that's not a vigorous debate. That's, if you want to basically, kowtow in front of me and tell me that you agree with me with vigor, then we're happy to have that discussion. But if you actually want to point out something, no, go away.
As of today, there is no evidence that COVID vaccines killed 10 children in the U.S. There's no evidence that it's been covered up. There's nothing. This letter is irrelevant. They have not released anything, and they're not going to because there is no evidence.
And he even writes out, he goes, you know what? And don't talk to me about the over 1,000 children that died of COVID. That shouldn't even be in the discussion. I mean,
that's absurd.
Yeah, the 1,000 kids, over 1,000 kids that died, as we knew, dozens died this last year from COVID. Children are still dying from COVID. And we have tens of thousands of children in the U.S. who got COVID and who are still disabled with post-COVID conditions.
That's just a person who doesn't want that to be part of the equation. So he says, no, don't mention it. But it should be. Of course it should be.
Don't mention that. That should be. I mean, that's one of the biggest reasons we vaccinate children, not only to prevent them from dying, not only to prevent them from ending up in the hospital, but clear evidence that this decreases their risk of these long-term sequelae. All right. And another thing, and this actually dovetails onto this, because this should have been something that was being discussed at the CDC, the ACIP meetings. And this is this movement to, do you really need multiple doses of the HPV vaccine, or can you just get one and be covered? And that would also, increase the ability to get this protection out there. So we'll discuss this, and this is the article, Non-Inferiority of One HPV Vaccine Dose to 2 Doses. This was recently published in the New England Journal of Medicine. And why am I talking about this in our clinical update when it seems more like a specialty article? Well, Unfortunately, it is because this is also an issue related to our loss of the US CDC as a source of evidence-based guidance. Here, these investigators assessed whether one dose of an HPV vaccine was non-inferior to 2 doses. So they've got girls 12 to 16 years of age randomly assigned in this 1-to-1-to-1-to-1 ratio. They're going to receive either 1 or 2 doses of the bivalent HPV vaccine or 1 or 2 doses of a non-avalent HPV vaccine. The primary endpoint was new HPV type 16 or 18 infection occurring from month 12 to month 60, persisting for at least 6 months. The pre-specified non-inferiority margin was 1.25 infections per 100 participants. They assessed vaccine effectiveness. Really, just to cut to the chase, the vaccine effectiveness was at least 97% in each of the 4 trial groups. So among 20,330 participants, no safety concerns, 1 shot looked like it was doing the job.
It's very good.
I mean, it's amazing. And this vaccine, we've discussed multiple studies where it prevents cancer, it prevents genital warts. This is a cancer vaccine. If we can get our kids all vaccinated, if we can reduce the circulation of HPV in our population, we can not only reduce all the cancers for these young women, but as we've talked about before, significant impact on head and neck cancers. All right. But they're going after the HPV vaccine because, again, there's money. There's money there for, Kennedy and his cronies. All right. Marburg in Ethiopia, we have an update. Ethiopia's Ministry of Health has reported 13 lab-confirmed illnesses, including 8 deaths from Marburg virus, right? So that's the cousin of Ebola here. Additional illnesses are under investigation, so we'll keep people updated. Actually, the DRC Ebola outbreak is over, so they made it past that, so that's great. I forgot to mention this last week, but I will mention it this week. Bird flu, right? That gentleman in Washington who got the H5N5, he actually died from that. All right, measles still going strong. It's, I guess, part of making America great again. As of December 2nd, a total of 1,828 confirmed measles cases. So keep seeing more measles cases. Up there in Canada, another 40 new measles cases. We're up to 5,262 there. Still seeing more measles cases down south of us in Mexico. All right, flu's here, Vincent. It's here in the New York area. We're starting to see the admissions in the hospital. Had some more consultations. We're seeing a lot of the H3, influenza A. And some of these folks are getting really, really sick.
So they come to the hospital because they have trouble breathing, is that right?
Yeah, so they have trouble breathing. They require supplemental oxygen. They're not doing well at home. Some of them are falling down, being found on the ground.
Are they generally older?
Generally older, yeah.
Okay.
So, and I am, oh my gosh, if we look at our map, it looks like Colorado and Louisiana are not the places to go visit. And where am I going to go? To Colorado. They got high activity there. So I'm going to
Louisiana is very high. That's interesting. I wonder it's because so many people travel there, right?
I wonder. Yeah, I don't want to go to New Orleans. And they sort of started off with some early activity. And now, everyone's got it in Colorado. And we're starting to see plenty of activity. New York City actually is already moving into kind of the moderate level.
Yep.
So, if you look at the percentage of those tests that are positive, we're seeing a nice uptick. But it's really interesting to compare, flu in general. Once it starts to go up, it goes up, it peaks. We usually get a couple months of really bad flu activity, and then it comes down, and usually we get a break. Where, as you see, COVID sort of bounces around, it goes up, maybe not as high, comes back down, a couple peaks a year. We had nice, this last summer was more than last winter. So, and as I want to keep reminding people, because of the reduction in flu vaccinations of the little kids, we had over 280 influenza-associated pediatric deaths last season. So not great. It's still not too late to get those flu shots. All right, RSV is ramping up as well. One of our local hospitals got a couple adults on the ventilator with pretty severe RSV, severe enough to require being on a ventilator. We're starting to see some pediatric ICU admissions with RSV as well. It's just starting to pick up, so the ER epidemic trend is really moving in the wrong direction. So sort of looking at an early, December increase in all this activity.
So there's still time to get vaccinated, right?
Yeah. So for the RSV, right, what are the vaccine recommendations? So the CDC recommends everyone 75 and older get the RSV vaccine. We've talked about the 1 to 2 million, so 1 to 2 cases per million vaccines of getting the Guillain-Barré syndrome, but the quadrupling of that baseline risk of thousands of people getting Guillain-Barré from RSV vaccine and from RSV disease itself, right? So actually the sort of an interesting calculation, the CDC recommends adults 50 to 74 at increased risk of severe RSV disease get the RSV vaccine. We recommend women in the 32 to 36 weeks gestational age get the RSV vaccine. We recommend the little kids who are going to be in the first year of life go ahead and get the monoclonals, so the passive vaccination. That's the nirsevimab and the clesrovimab. So yeah, there's still time to do all those things. And do they work? We have the nice article, Maternal and Neonatal Outcomes After Respiratory Syncytial Virus Prefusion F Protein Vaccination During Pregnancy Analysis from the 2024-2025 Immunization Campaign in France, published in the journal Obstetrics and Gynecology. So this is the professional organization journal. They use this national healthcare database, which covers almost 99% of the population in France. They included all women who gave birth after 22 weeks of gestation between September 16 and December 31, 2024. So this is data from last year. Women vaccinated with the RSV pre-F were matched 1-to-1 with unvaccinated women. And then they're going to go ahead and they're going to look at these outcomes. Among 29,032 women vaccinated, 24,891 were successfully matched to 24,891 unvaccinated. No significant increase in any of the bad outcomes, right? So we're looking here at safety issues. So they looked at preterm birth, delivery within 1 week or within 3 weeks, stillbirth, C-section, small for gestational age, postpartum hemorrhage, preeclampsia, major adverse cardiovascular events, which actually were significantly, were lower, but not statistically significant lower. No increased risk of any of these bad outcomes. So great safety profiles.
So this was a safety
study.
Yeah. Okay.
Yep. So this is the Pfizer Abrysvo. That's the RSV pre-F.
Now, just to put things in perspective, so, they're talking about 30,000 people or so in this study.
Yep.
And in his letter, Prasad says these studies are too small to find signatures of side effects. Well, you can't do millions of people. You have to start small, and then you license, and then you look and see what happens. You do post-licensing monitoring. That's the only way you can do it. Otherwise, you won't have any vaccines.
Yeah. I mean, this is a post-licensing study in France. Yeah. They're looking at 99%, so basically the tens of thousands of eligible women, and they're not seeing any issues. And they're looking. We're looking.
But obviously, if something is 20 per million, you're not going to see it here.
Yeah. Maybe over years you might start to pick up. But what we are seeing, right, is, these 30-40% reduction in the little kids ending up in the hospital, right, ending up dying, ending up having a lifetime of asthma. I was talking to a pulmonologist last night, actually, about this. One of the things we don't think about is you get a bad RSV infection that lands you in the hospital, and you think, okay, we got through that, but now your kid might end up with asthma for the rest of their life.
That's right.
So, and we can do stuff. We can do stuff about that.
So it's always about weighing risks versus benefits, right? there's no other way because everything has an inherent risk.
And the whole idea that, but you'll get RSV, what doesn't kill you makes you stronger. No, what doesn't kill you might leave you a little bit crippled with lifelong asthma or some other issue.
Yeah, the chances of that happening are too great. They're much greater than the 1 in a million side effects, right?
Yeah, you might turn into a heroin addict or, become addicted to nicotine and tanning beds. Bad things can happen. Even if you avoid ultra-processed foods. Oh, you thought I was talking about someone.
I thought you were talking about someone.
Yeah. Okay. All right. COVID. We've got our multicolored lines back. Might be seeing a little bit of an uptick in activity, but still things are kind of in the low. Yeah.
If you have an imagination, you can see a little bit of an uptick. We're at the high end of the very low, right? Just crossing into low.
Yeah. So we'll see. We'll kind of follow that over. Is it going to, I was talking to ER doc. It was actually a hospital event. That's why I was talking to all these doctors. Usually I try to avoid them. Well, I work in a hospital, so I talk to doctors all the time, I guess. But no, they were wondering about, is it going to be all three at once? We're starting to see flu, or are we going to see RSV and COVID? It's going to be all three at once. So we'll see. I mean, there are certain areas where the epidemic trend is going in the wrong direction, right? Colorado, again, we're happen to be heading, Pennsylvania, Jersey, some of the local areas. So we'll see what happens over the next little bit. But those vaccines, which they claim we don't keep an eye on, we are still keeping an eye. We've got another article, and this is effectiveness of COVID-19 vaccines against post-COVID-19 condition long COVID. It's a systematic review meta-analysis published in CMI, right? So I put it here because I want to put it in our vaccine section. The aim of this review was to evaluate the effectiveness of these vaccines in preventing post-COVID conditions or long COVID. And so we're going to get data for just any vaccine at all. And then we're also going to get broken down for if you got 1 dose, 2 dose, 3 doses. So if you just got any at all, 1 or more vaccine dose, 41% reduction in post-COVID conditions. So that's huge. I mean, for most of us, right? Most of us are not going to die from COVID. Most of us won't end up in the hospital, but probably the biggest issue is you get COVID and then you're just not better for months and months.
So they have less than 18 years of age, right? 26% efficacy. And then over 60, 41%.
Yeah.
So you still can get long COVID over 60.
Oh, yeah. We see it in all the ranges. We see it, young kids can't go to school. We see older folks, it's just miserable. Yeah.
So last night on the stream, a guy asked, I have a 20-something son who got the original 3 COVID shots. Should he be getting boosters? And I said, well, I can't give you medical advice, but Daniel would probably say, there's a reduction of long COVID, and maybe for a young person, that's the thing you would vaccinate for. What do you think?
So I'd say yes. And if you sort of break this down, right? So if you get just a 1 dose, that's about a 19% reduction. You get 2 doses, that's 43. You get 3, that's 70%. So we're really seeing that the more doses of vaccine, we're seeing an escalation in the reduction. So, folks that have gotten all the vaccines, that have been getting yearly boosters, really protected against long COVID. So, yeah. And every time you get COVID, you're at risk. So if you can even reduce your chance of, symptomatic COVID, you're going to reduce your risk. Even asymptomatic COVID can give you long COVID. So, all right. And what about, and I keep criticizing, what about looking at infection, SARS-CoV-2 infection versus vaccination during pregnancy? And this is implications for placental antibody transfer, published in the Pediatric Infectious Disease Journal. So here we've got prospective, multi-center observational study of SARS-CoV-2 infected and or vaccinated pregnant people and their infants. They collected maternal and cord blood samples at delivery and neonatal infant samples at delivery, 1, 2, 6, and 12 months of age. They're going to look at all the different antibody titers. They collected blood samples from 193 pregnant people. 96 are infected, 60 vaccinated, and then 37 infected and vaccinated, so that hybrid. And then they're going to look at 154 infants, and then 76, 47, 31, respectively, associated with the ladies. Now, at birth, they're going to look at the titers of the RBD median from infected, vaccinated. They're going to compare it across. Basically, what we're going to see is the hybrid, right? So being vaccinated is better than being infected. Being infected and vaccinated is going to give you the best transfer of those antibodies. And then actually you're going to see, like, if you sort of adjust for a trimester of infection and vaccination, sort of that last trimester is going to give you the most transfer. All right. Moving through, say, we're not seeing a lot of COVID activity, but when we are still, remember, that we end up with people dying, we end up with people in the hospital, we end up with people with long COVID. So still recommending early antiviral therapy. Moving into the inflammatory period, we're still using steroids and immunomodulators in the right people. But really the big thing we're struggling with is all these sort of growing crowd of folks who have long COVID that refractory to a lot of the techniques. So sort of an exciting publication this week sent to me by the authors who I actually know, because Columbia, we're setting up to do a stellate ganglion block study there that's funded from the recovery funds. So here's this article. Case report, celiac plexus block improves gastrointestinal long COVID symptoms, published in Frontiers in Neuroscience. So what did they do here? So they do this block using a posterior approach, and they have the great figures. I love the figures. So what you have is this idea that an imbalance between the amount of sympathetic activity, so increased sympathetic activity, and not enough parasympathetic activity, so this autonomic nervous system imbalance, might be driving a lot of long COVID symptoms. And in this case, may be driving epigastric pain, this diarrhea that we're seeing. And so what they're going to do, instead of doing the block of the sympathetic ganglion in the neck, they're actually going to go in, they're going to like sort of skirt the side of the spine with these needles. They're going to get into the celiac plexus, and they're going to do a nerve block there to try to decrease the sympathetic tone, or really shut down the sympathetic tone in the gut. And this case report of 3 individuals where they do this with great figures of seeing exactly how they do this. And in these 3 individuals, one of them had complete recovery, and the other 2 had near complete recovery after going through this.
So how do you do a block? Do you inject something?
Yeah, so you're going to actually, from the person's behind, so you're behind the person,
yeah,
and it's the lower
L1.
Yeah, it's L1. So it's right there below the thoracic, right? So lumbar 1. You're going to go right in along the lateral side of L1 from the person's back. You're going to skirt, and then you're going to get just in front of the vertebrae there. And that's where this celiac plexus is. So you're going to actually inject into that area.
And you have to avoid the kidney.
Yeah, so you're going between. Yeah, that's why you're hugging the vertebrae. And you're doing this, they actually show you the fluoroscopy guided images. So you get right in there. You don't poke the kidney. You're going to skirt right along the bone. You get just in deep enough. You don't want to keep going, end up in the guts. And then you put it in there.
And then, so people felt better. Do we know how long it will persist? I mean, maybe after the treatment wears off, it comes back.
Yeah, I mean, this is a preliminary, right? Like how long is this going to last? 3 is a case study. It's interesting, but we really need to do studies, and again, they need to be done right. Like we talked about the sham where they did the stellate ganglion in the neck, and then so some people were getting like a lidocaine, like a long acting, but then other people were getting these like saline put in there. And, they seem like you were probably getting some degree of a block by just putting a massive, pressure of saline in the area. So you need to somehow do a sham, which isn't actually getting any kind of sympathetic block.
And so this is often done for abdominal pain, right?
Yeah. So, we're starting to see the same group that was doing stellate ganglion blocks doing it now for abdominal pain. And we certainly see a lot of this. So. Interesting. We'll have to follow that, but really preliminary case study at this point. All right. So another article, this will be our last long COVID article this week. Distinct brain alterations and neurodegenerative processes in cognitive impairment associated with post-acute sequelae of COVID-19. Now, this was published in Nature Communications, so you can imagine this is quite a handful to get through this paper. So this will be a brief sort of overview. So what these investigators did is they analyzed blood proteins and brain MRIs from individuals approximately 1 year after mild COVID-19, categorized, you're going to have to remember these acronyms, COG-PASC, so that's cognitive impairment, so cognitive impairment PASC, and then other PASC, so without cognitive impairment. They should just call them the COGs and the non-COGs, right?
Mm-hmm.
Or maybe the non-COGs would be the people who are having cognitive issues. So maybe it gets confusing. And this is an exploration cohort. They looked at those with COG-PASC, so the cognitive impairment PASC. They had elevated astroglial damage-associated proteins, structural and microstructural alternations across various regions. They mention those regions. I won't, because I think you need the people this week in neuro to go through. And they're matching age, sex, education. They're seeing cortical thinning. Blood proteomics reveals these different patterns with oxidative stress responses and synaptic function being different in the people with COG-PASC, linked to neurodegenerative pathways. I think the biggest thing I take away from this really complex, challenging study is they're actually seeing reproducible neurodegenerative associated alterations, objective evidence that something is going on in these folks that have COG-PASC that is not going on in other PASC subtypes. And this is after just mild COVID-19 infection.
Could this be the basis of a diagnostic test, perhaps?
Potentially, actually, right? Or when these people are having issues where insurance is not helping them, when they're not getting disability, people say, no, they have like objective findings of these neurodegenerative processes. And maybe, we can figure out ways to intervene. Why is this going on? Is this because of like a herpes zoster reactivation or some other viral reactivation, or is it just an ongoing inflammatory process that we can target? So, all right. So no one is safe until everyone is safe. We are in the middle of our Microbe TV fundraiser. I want to thank everyone that's really stepped up because, Vincent, as you keep saying every week, we only do this with your support. We don't take big pharma dollars. We don't take like advertising. It's really our listeners sending in whatever you want to send in. So go to parasiteswithoutborders.com, click on the donate button. We're going to get up to that maximum donation of $20,000. We're going to double things to get to that level to support Microbe TV.
It's time for your questions for Daniel. You can send yours to daniel@microbe.tv. Ingrid writes, I got hooked on TWiV during the pandemic and have continued to enjoy the clinical updates you provide. I'm currently 37 weeks pregnant with our third child and navigating a different world in terms of vaccines and exposure compared to the first two. Just last week, my stepmother-in-law was hospitalized with H. influenza type B, Hib. She had a pretty serious case, was in the ICU for a few days. Thankfully, she's doing better. My father-in-law was around her while she was sick. He lives in Ohio and we live in Colorado, and he's scheduled to come out in 10 days to be here for our older two kids for when I go into labor. We're questioning whether that's wise given his recent exposure to Hib and the fact that we will have a newborn who can't be vaccinated against Hib arriving sometime during his stay. We've contacted our pediatrician, midwives, and even local public health and gotten conflicting responses as to whether it's safe for him to come out, if he should do prophylactic antibiotics since he was exposed and could be asymptomatic, or if the most prudent approach is for him not to come. While this would be inconvenient, we will, of course, do this if the risk is too high. With that in mind, a few questions. One, it sounds like prophylactic antibiotics for my father-in-law would be our safest bet. that still allows him to come out and help. Are there any guidelines as to which antibiotic for how long and whether he needs to complete the treatment course before being around our newborn? Or would you recommend he not come out at all until the baby can be vaccinated? He will contact his PCP, but we want to be armed with good info as this is a unique situation. Okay, let's do that one first.
Yeah. So, wow, this is very similar to the woman that I was consulting on today, right? So, Haemophilus influenza type B, bacteremic, sick in the hospital. We're trying to figure out if it may have gone to the spine, whether or not this woman now has spinal osteomyelitis. And I was talking a little bit about Haemophilus influenza. So, actually, this will be a good primer, I guess we say. So people get confused. Haemophilus influenza. Why do we call this influenza? And I don't know if you know this history, Vincent. It's I don't know. I think it's interesting. There was, what was his name? Pfeiffer? What was his name? This doctor who thought that this bacteria was what was causing the 1918 flu pandemic. And they actually called it Pfeiffer's bacilli. And there were some studies, hey, we're isolating this in about 20% of these kids in the military barracks that are dying of flu. And they sort of thought of it as a smoking gun. It probably was just a bacterial secondary infection of people with viral flu. But that's why it's called influenza. Haemophilus influenza.
Used to be Bacillus influenza, actually.
Yes. And what, was it Pfeiffer? Was that his name?
Yeah, Pfeiffer was his name.
Yeah, Dr. Pfeiffer. But so time goes by, right? This continues to be an issue. It causes ear infections, causes meningitis, and then the Haemophilus influenza type B vaccine gets introduced. So during my sort of career from last century to now, we really stopped seeing Haemophilus influenza. It used to be very common. But now, as we're seeing decreased vaccinations across the board and delayed vaccination, we're starting to see cases. This is not the only case that I've seen in the last few months. We're seeing bacteremia again. We're seeing ear infections again. We're seeing meningitis again. And it's kind of uncharted waters, right? Because it used to be super common. There wasn't really a concept of prophylactic antibiotics because it was, during sometimes maybe 20% of the pneumonias, a chunk of the meningitis would get this. So really, you're kind of in these uncharted waters, right? So the woman that I talked about that I took care of today in the hospital, she's working in a sort of a preschool daycare situation. Some of those kids are unvaccinated. We had a discussion with her and her husband about that. In this situation, there probably was some exposure from now that we're seeing it more in the population. If the mother-in-law is hospitalized, was the father-in-law also colonized? Is he also colonized? We're in an age group where we didn't really get the Haemophilus influenza vaccine because it wasn't part of the schedule, because it really was the youngest kids that were having the issues. And then we as adults were getting the benefit of sort of bystander from that. These bacteria are pretty susceptible to our cephalosporins, so like a cefuroxime, 500 milligrams twice a day for a week would be a potential way to do a prophylactic antibiotic treatment. But again, really uncharted waters. We don't have any really good evidence-based studies or guidelines to go with on this. But I think all the things you're thinking about are true. This is an individual who's been exposed with someone who was hospitalized. They may be colonized. We're entering this world of little kids who are not old enough to be protected themselves, and the world around us has just said, too bad, we're not willing to do what it takes to keep the little babies safe.
All right, second question is, I was immunized against Hib in the late 80s when I was 18 months old. It looks like I received just one dose. Should I consider getting Hib vaccine while still pregnant to try to transfer some immunity to the baby? I'm 37 weeks plus 3 days today, so my window is closing.
Wow. I mean, scientifically, it makes sense, right? If you get vaccinated, there's enough of a period of time for some passive transfer to the baby that potentially can provide some protection. I mean, again, this isn't something we've studied. It's really sort of thinking through the science on this. And we may have to actually start really doing these studies and thinking these through because, as I mentioned, the world around us is not embracing vaccination So as we see dropping rates, we could have more and more babies born into a world where until they're old enough to get their own vaccinations, they're potentially going to be exposed to other folks who didn't do their part.
Michael writes, my wife and I had a baby in mid-January 2024. During that pregnancy, she received Abrysvo to protect the baby against RSV once he was born. She's now pregnant again, due at the end of January. She was told by her OB that it isn't recommended to get Abrysvo during pregnancy if you've previously received it. We checked the CDC and ACOG recommendations and both agree that in this case the baby should receive a monoclonal, either nirsevimab or clesrovimab. Why would the RSV vaccine not be recommended? For instance, is there some reason to think that the mother wouldn't produce enough antibodies to protect the baby, or is there some other reason not to give it?
Yeah, so this is interesting, right? And we've talked a little bit about the data that can sort of drive this decision. So adults, right? You're an adult, but we're talking about older adults. I think when we're talking about RSV studies, they get their initial shot, and then it was, should you get another shot a year later? Should you get another shot 2 years later? And if you do get that shot, what happens? And we weren't really seeing a boost in those antibody levels that we sort of expected, because we sort of thought, okay, well, looks like you're still protected into that second year, but maybe then it's time to get a boost and see those antibodies come up. And we didn't really see those antibodies come up. So, that's sort of translating here. It's not clear if you got that nice boost and that transfer during the first pregnancy, if going ahead and getting another RSV vaccine is going to get you that boost. But it's okay, because the passive antibodies, the monoclonal antibodies that give to the baby, nirsevimab and clesrovimab, are very effective. So that is an excellent option. So I would say go ahead with this pregnancy. When this baby is born, the baby should receive a monoclonal.
Carl writes, a study in Canada suggests that Paxlovid is very helpful for unvaccinated individuals with COVID, but not nearly as helpful for fully vaccinated individuals. I'm 70 and in decent shape and chose not to take it when infected in October. I did okay with no rebound. Shouldn't this conflicting evidence about Paxlovid be more widely discussed on TWiV?
Carl, we talked about that study and all its many flaws. The thing, even to this day, like I know, up in Canada, right, we're trying to save money. You're over 70. I remember when my dad got admitted to the hospital in France, and it was after 2:30 in the afternoon. And the doctor explained to him, because, your dad's in his 70s. People in their 70s die. It's already after 2:30 in the afternoon. I'm not going to have a doctor come back this late in the day to see your dad. If he's still alive tomorrow... I'm like, oh my gosh. And then there was a pause. He goes, you do realize people in their 70s die? I said, yes, but I would like if my dad in his 70s did not die. So, I don't know if I could say welcome to, a public health system, but, you're over 70, Carl. Come on, you've lived long enough. Paxlovid, it's going to reduce your chance of dying, of ending up in the hospital. But you're over 70. It's a lot of money for that Paxlovid, Carl. So we talked about this. Study, and the percent decreased, but then the numbers needed to treat. You probably have to treat a bunch of people because you've been vaccinated, you've been infected before. Your chance of getting up in the hospital is low, but you can make that even lower.
So basically, it was a flawed study.
I think of it as a flawed study.
Okay. Robin writes, I've been a listener of Microbe TV since the pandemic and so grateful for the work of all you do to present science and education to us. I am a 79-year-old retired RN in generally good health. I exercise a lot, have a healthy lifestyle. I've had rheumatoid arthritis for 20 years, well controlled with Rituxan. I had 2 doses of Evusheld when it was available, and in April 2025, a dose of PEMGARDA. In May, I had a short episode of atrial fibrillation. In July, August, and October, 3 more severe episodes that required cardioversion. I've since had a pulse field ablation and seem to be fine. Other than being oldish, I have no risk factors. And after quite a bit of digging, I found an article that mentioned a correlation, not causation, I know, with arrhythmias and PEMGARDA. I talked with my rheumatologist recently about revisiting taking PEMGARDA again, as I'm at increased risk for severe disease and never had COVID. She advised against it, stating she had heard of cardiac problems associated with both Evusheld and PEMGARDA. What do you think?
All right, Robin. So this is a good one, right? Because we're sort of balancing things here. We're saying, if you get the PEMGARDA, maybe there's some correlation with arrhythmias. But you know what? There's a clear correlation with getting COVID. COVID certainly increases your risk of arrhythmia, certainly increases your risk of cardiovascular issues. So it's really kind of a risk benefit. Is there a connection? You're oldish, as you point out, and that can actually be when we start seeing more atrial fibrillation. You require the cardioversion. Let's see what you've also done.
Yeah, an ablation too.
Yeah, an ablation. So that's great. So it's really going to be a risk benefit. So, have that discussion, but sort of think about the issue that, you kind of look at this two ways. If you get PEMGARDA, you have another issue of AFib. You're going to regret that decision. If you don't get PEMGARDA, you get COVID, and then you end up with AFib or another issue because of the COVID, you then kind of have that. So you got to weigh the risks of, every choice is a choice. Deciding to get PEMGARDA is a choice. Deciding not to get PEMGARDA is a choice.
So even with an ablation, you could have another AFib, right?
You could. Yeah.
That's TWiV Weekly Clinical Update with Dr. Daniel Griffin. Thank you, Daniel.
Oh, thank you. And everyone, be safe.